Stanford University.
First, I am going to provide about a 20-minute introduction to the field of heart failure and cardiomyopathy, and then Joe will tell you about the work that he is doing in the area of stem cells to repair a broken heart. So let me tell you a little bit about Joe, and I've got his CV up here on the screen here because I wound up getting a copy of it only about 5 minutes ago. This is the amazing thing about the internet. I once was giving a lecture at a local biotech firm, and there was a really great paper that had just been published in the journal Science that week. And I had my slide ready to go, but I had about 10 minutes before the presentation. So I literally sat at the computer, logged onto the internet, got the article, took one or two of the figures, pasted them in my presentation. 5 minutes before we're ready to go, it was there. And that's something we certainly couldn't do in the era where we were still using slides. Joe is started his medical career at UCLA, where he did his undergraduate degree in biology, then traveled to the East Coast to Yale for his Doctor of Medicine, and then came back to UCLA, where he then did his PhD in molecular pharmacology, as well as his residency and fellowship in cardiology before coming and joining the faculty at Stanford. His accomplishments are really incredible for someone at his stage in his career. His main focus is in the Department of Medicine and Radiology, but he's also a member of the Stanford Institute for Stem Cell Biology and Regenerative Medicine. And if this mini-med course works out well, we're hoping to convince the stem cell and other institutes to follow with other courses of their own. Dr. Wu has received the Burroughs Wellcome Foundation Career Award for Medical Scientists and a very prestigious NIH Director's New Innovator Award in 2008. He's received multiple grants, both from the NIH and this California Institute of Regenerative Medicine. And his lab focuses on the biological mechanisms by which stem cells develop, how they differentiate into different tissues, in particular tissues that repair the heart. And his particular interest is in a unique form of cell called an induced pluripotential stem cell. And I won't tell you much more about that because I think that's going to be a lot about what Joe's going to talk about. But I think Bobby Robbins and a few others hinted at that in their earlier lectures. So before we let Joe talk to you guys, I thought it would be worthwhile to focus a little bit on the concept of heart failure and what we talk about when we talk about cardiomyopathy and heart failure. So, you know, I give a talk to the emergency room residents every year about how they should manage patients who come in with heart failure. And of course, if you watch the standard kind of TV shows, they do everything. They make the diagnosis, they do the heart catheterization, they do the treatment, they put the patient on an artificial heart, and they actually, I think on ER, they even did a heart transplant down in the ER, all within a prime time hour with plenty of room over for commercials. So our emergency room at Stanford isn't quite that fancy, doesn't quite get equipped quite that way. So let's talk about heart failure. What is heart failure? Well, it's been recognized for quite a long time. I don't know if anyone read the supplement on Leonardo that came out with this week's reading, but certainly Leonardo didn't recognize it. But back in the early 1800s or even the late 1700s, carditis was first used as a term by James Johnson. He had an unusual position. He was called the physician extraordinary. What a wonderful term. Imagine, you know, those of you who are engineers being appointed the engineer extraordinary. This meant that he was the personal physician for the king, a really honored position. And so he described pyrexia, fever, dolor in region cordis, chest pain, anxiety, difficult spirit, tussis, cough, unequal pulses, palpitations, feeling your heart skipping beats, and syncope, fainting. Some of the original terms used to describe the constellation of what we call heart failure. One of the greats of more modern medicine, William Osler, who was one of the founding quartet of the Johns Hopkins School of Medicine, talked about idiopathic dilation of the heart. Idiopathic essentially means we don't know the etiology, don't know the cause of the problem, and dilatation is just an enlargement. And in 1892, he wrote, "There are other causes in which dilatation of the heart occurs without discoverable cause. In some instances, there has been a history of sudden exercise or of mental emotion, so potential connection between the sympathetic nervous system and emotions and the heart. But in other cases, the condition seems to have come on spontaneously. Death may occur in a few days, or dropsy, which is edema, fluid overload, may supervene, and the case may become chronic." And he actually proposed the first version of what we now regard as pre- and afterload reduction. We'll talk a little bit about that. Is venesection in many cases is the only means by which the life of the patient may be saved, and that essentially is bleeding the patient. Subsequent advances in heart failure management included something that is called rotating tourniquets. And actually, when I was a college student and worked at a summer camp for kids with heart disease, when one of our patients went into heart failure, the doctor at the time applied rotating tourniquets, placing a tourniquet on each limb, successfully tightening them in order to reduce the amount of fluid that was coming back from the body to the chest. And it was a technique that actually worked in the days before many of the modern medicines we have today. Fibrosis, scar of the heart, was first recognized actually even before that in the early 1800s. The idea that some heart disease was due to an inflammatory process, myocarditis, the finding of white blood cells in the heart muscle, was first recognized again in the early 1800s. And of course, then the discovery of the infectious process led to the idea that some of these processes of inflammation could be due to viruses. And in fact, it wasn't until the 1940s where someone actually discovered, in fact, or proved that viruses could inflame the heart with the recovery and the growth of a virus from a patient with myocarditis. It then began to be recognized that sometimes this ran in families. And that there therefore was probably a genetic cause. And then the first description of myocardial disease in children was by Alex Natus in 1953. The first term, the use of the term hypertrophic cardiomyopathy, was in 1958. So that gives you a little bit about the history. What is the impact of heart failure on our population? 5.8 million Americans are living with heart failure, and over 600,000 new cases are diagnosed each year in the United States. This comes off the CDC's website. Over 5% of persons aged 60 to 69 have been diagnosed with heart failure, but this does affect younger people. 2% of patients age 40 to 59 have heart failure, and although heart failure is rare in children, we right now have 5 kids in the hospital at Packard Children's who are suffering from some form of heart failure, and 2 of which are on artificial hearts to treat the heart failure. It is equally frequent in men and women, although there are some racial and ethnic discrepancies, and African Americans in some reports are up to 1.5 times more likely to develop heart failure. If you're living in California, your chances of dying from heart failure is probably a little bit less than in some of the other states. Some of these increased risks follow some of the natural risks that one are associated with heart disease, such as increased risk of obesity, increased risk of hypertension, and so heart failure is certainly linked to those. There are more hospitalizations in the US each year, almost 900,000, than all cancers combined. 283,000 deaths per year as of 2008. 20% of patients who have heart failure will die within a year of their diagnosis, and over 50% of patients with heart failure will be dead within 5 years. So it is certainly a major health problem. The cost to the US economy, depending on how you calculate it, but if you look at not only medical costs, but lost productivity, is almost $40 billion a year. So what is this? What is this syndrome of heart failure? Why does the heart stop working well? Well, cardiologists think of heart failure as a symptom complex and a physiologic event, but the primary problem with the pump is called a cardiomyopathy. It essentially is a muscle disease of the heart. So what causes this? How do we think about this? Well, one of the ways that you can classify it is by what it does to the patient's cardiovascular system. So we can classify it by its effect on your physiology. And in that case, we can say that patients have one of 3 different types of heart failure. They have either dilated cardiomyopathy, which affects systole. That's the active phase of contraction of the heart. They have hypertrophic cardiomyopathy, which predominantly affects diastole. That's the relaxation phase of the heart. Or they can have a disease called a restrictive cardiomyopathy, which tends to affect diastole, but also sometimes systole as well. So let's take a look and see what some of these look like. So on the first lecture, I think we showed you what a normal chest X-ray looks like. Here again is the normal structure of the heart. You can see the lung fields here are relatively black because they're filled with air. You can see little tiny blood vessels here. This is a patient with a very enlarged heart. It's not uncommon to see this at first presentation where a patient shows up in the emergency room complaining of trouble breathing. Maybe they haven't been able to exercise well for the last couple of weeks or months. So this is a sign of an enlarged heart. And then on the second X-ray, you can see in this patient, the heart is not as enlarged, but there is enormous amount of this white fluffy stuff in the lung fields, and that's what we call pulmonary edema. So basically the pressures in the heart are high, the pressures are backing up into the lungs, and fluid is seeping out from the capillaries surrounding the air sacs into the air sacs, and you can imagine how difficult it would be to breathe with a chest X-ray with the lungs that look like that. This is a drawing by Frank Danner of a patient with a dilated cardiomyopathy, and you can see here in his description here, the heart is enlarged. There are all these white areas in the red muscle, and that's areas of scar tissue or fibrosis that forms after heart muscle cells have been injured. This is an echocardiogram actually on a little boy that we saw in our clinic today, and you can see here the heart beating. Here's the left ventricle, the main pumping chamber of the heart. There's the aorta coming here. And you can see that this muscle is actually squeezing pretty well. This next echo is on a little girl that we took care of, probably about 4 months ago, 3-4 months ago. She was admitted to the hospital. She was only 5 months of age. And here you can see the left ventricle, and it is hugely enlarged. And if you look at the wall here, this is the wall between the 2 ventricles, the septum, it's not moving at all. So this heart is essentially almost not squeezing at all. Here you can see the mitral valve opening, trying to open and close, but this heart function is extremely poor. She was suffering from a dilated cardiomyopathy. On the other hand, if you look at this Netter drawing, you can see an example of what's called a hypertrophic cardiomyopathy. So in this case, the heart muscle is extraordinarily thick. And if you can imagine, if you had a balloon and you were trying to blow air into the balloon, if the balloon was relatively thin-walled, it would be fairly easy to inflate the balloon. On the other hand, as you thicken the rubber that the balloon is made out of, it's going to be harder and harder. You're going to have to use increased pressure in order to distend that balloon. And of course, if the walls of that balloon were 4 or 5 or 6 times thicker than normal, you can imagine it's going to be very, very hard to inflate that balloon. And essentially, the physiology with hypertrophic cardiomyopathy is very similar. So this heart muscle, in fact, is going to pump really well because there's more muscle there. It's going to actually pump quite effectively, but it can't fill with blood, and therefore the pressures during diastole, the resting phase of the heart cycle, become elevated. And here's an echo of a patient. You can see there's hardly any chamber for the blood to enter into because the heart is essentially all this thick muscle. Here's another example, and you can see how thick the muscle is here. Here's the mitral valve and the aortic valve. Here's the left ventricular wall. Here's the septum between the two heart chambers. This is a patient with a hypertrophic cardiomyopathy. Sometimes these patients have the thickness of the muscle limited to one part of the heart only, and here's the left ventricle and the right ventricle, and here you can see it's only the wall between them. It's only the septum that causes that, in this case, where the muscle is thickened, and that can actually sometimes cause blockage of blood leaving the heart going out the aorta, and we call that idiopathic hypertrophic subaortic stenosis, or IHSS, is an old term we used to use, but it describes the phenomena where the heart muscle itself is blocking the blood from exiting the heart. And that's another problem that patients with hypertrophic cardiomyopathy get into. When you and Ashley talks to you in a couple of weeks, you'll learn about the role of hypertrophic cardiomyopathy in sudden death in athletes. And finally, this is Netter's drawing of a restrictive cardiomyopathy. And if you look at the inside wall of the heart here, it's all white and essentially been replaced by scar tissue. And this is an example of a condition that we sometimes see in young children. It's called endocardial fibroblastosis. There's some links to this and intrauterine infection with the mumps virus, which fortunately, because most people are immunized against mumps these days, has reduced in frequency quite considerably. But when you see a patient with restrictive myopathy, the ventricles themselves look like they're pretty normal, and actually they work fine, but they don't fill with blood very well. It's not that they're thicker, they're just stiffer because the heart muscle is essentially scarred down. And what happens is the atria, the small receiving chambers, become ballooned out because the blood essentially is backing up into these chambers. And these patients, again, have lots of problem with fluid in their lungs, fluid other parts of their body. The other way that you can look at cardiomyopathy as a disease is to classify it by what causes it, by etiology. And we can divide etiologies up into primary versus secondary causes. So let's talk about secondary causes because they're the most common. And the most common in adult patients is ischemic, is related to coronary artery disease, and ischemia essentially is a term that's used to describe not getting enough blood flow. So when you have a blockage in a coronary blood vessel, some of the wonderful pictures that Bobby and Bill Fearon showed you 2 weeks ago, essentially the heart muscle either becomes starved of oxygen and can't function, or essentially the heart muscle dies, and that is what causes what we call a heart attack or myocardial infarction. But after you have that, your heart muscle now is replaced by scar tissue, and I'll show you some pictures of that, and essentially you wind up with scar that doesn't contract, normal muscle contracts, and since the heart, we believe, is not very efficient at repairing itself, essentially you wind up with just scar instead of where there should be muscle. There are metabolic causes of heart failure. Diabetes is a particular high risk. There are many infectious causes. We call those myocarditis, and certain viruses, even the common cold virus, can cause a cardiomyopathy. There are rare structural problems where in young kids, one of the coronary arteries, instead of coming from the aorta, comes from the pulmonary artery instead. And because the pressure in the pulmonary artery is lower than the aorta, once the kid is born, within the first few weeks of life, they essentially have a heart attack because they don't have enough pressure in that blood vessel to provide blood flow. There are many toxins which can do it. Patients with chronic alcohol abuse or many forms of drug abuse can develop cardiomyopathy. There is an anti-cancer drug called doxorubicin that we study in our lab extensively that is great for curing cancer, but it also has a side effect on the heart muscle, and that is a cause of cardiomyopathy, fortunately in only a small portion of patients who get that drug. Interesting enough, cobalt is a great story behind cobalt because many years ago there was a brewer up in Canada that found out that if you added a trace amount of cobalt to their brew, it made the beer have a larger head. It foamed a little bit more. And so they started adding cobalt to their brew, and there was an outbreak of patients who were coming in with heart failure and were coming in with cobalt toxicity traced back to that brewery. So there are a number of toxic substances which can also damage the heart. And then our own bodies can attack our heart. Patients who have autoimmune diseases like lupus erythematosus, rheumatoid arthritis, and diseases like scleroderma. These are rare causes of heart failure. But I wanted to show you a picture of what a heart attack essentially looks like, what myocardial infarct. This is essentially an area of tissue here. So the red stuff, this is the right ventricle, here's the left ventricle. The red stuff is the normal muscle. And you can see here, this is an acute infarct. This is hours old where you have damage to the muscle. And you can already see the muscle essentially, instead of red, is turning white. The heart muscle cells, if you looked under a microscope, would be dying at this point. But then if you look here, here is a big yellow scar, and then finally this white healed infarct, this scar here. And you can see here the entire septum and part of the free wall of the heart has already died. And so all this stuff is not going to be able to pump very effectively, and you're left with maybe a third or a little bit more of the ventricular wall that's capable of contracting. And so that is an ischemic cardiomyopathy. If you actually looked at it under a microscope at what this looks like after about 4 or 5 weeks, what you'd see is these are normal heart muscle cells here, but many of them are beginning to shrink, and they can shrink away from the area of the connecting to the other tissue, and they're beginning to undergo a process of cell death. You can see there's red blood cells in here, there's hemorrhage, and then there's all this scar tissue that's coming in, and there's inflammatory cells. So in this particular case, essentially the heart, the viable heart muscle cells have died and are being replaced by scar tissue. Unfortunately, heart muscle cells, unlike if you had if you cut your skin and the skin muscles died, you would essentially wind up replacing them and you heal the scar. And I think what Joe is going to be talking about in his talk is sort of figuring out ways to get the body to improve the process of doing that for the heart, because as far as the heart's concerned, most of its cells, once they're dead, will never return. In terms of primary genetic causes of cardiomyopathy, there are a number of different structural genes, and this list is getting longer and longer every week. But dilated cardiomyopathy can be due to gene abnormalities in genes that are the structural part of the heart. So if, in fact, if this was a building, it would be in the timbers used to construct it, in the structural elements, in the floor beams. These are the parts of the heart that are responsible for doing the work. Actin and myosin, troponin, these are all the components of essentially the motor of the heart. But the motor also needs fuel. And many of the genes that are abnormal in these muscle diseases affect the ability of the mitochondria, which is the workhorse of the heart, generates the ATP, which is the source of energy that's made from food and fuel with oxygen in order to have the heart muscle have the energy for all the motion and all the work it does. And as you can see here, there's a long list of the number of genes in those mitochondria that can be defective, that can, if you don't have, you can have a perfectly normal car, if you don't have gas to put in the car, it's not going to work. There are a number of these genes which are also can cause hypertrophic cardiomyopathy. And the interesting thing, and one of the things we really don't understand quite yet, is why, in fact, a mutation in a gene like the myosin heavy chain gene, one mutation in that gene can cause the heart muscle to thicken up, and yet another mutation in a slightly different part of that protein can cause the heart muscle to dilate in a totally different type of heart disease, but it's a mutation in the same gene. And finally, there are a number of genes now, this list is old, there are many more that have been associated with restrictive cardiomyopathy. There are currently companies that will do gene testing. So when we have a patient that we suspect has a familial cardiomyopathy, just saw a patient in clinic today whose little boy just had a heart transplant, and his mother and brother have been found to have the same gene defect that he has. And we know that because there's a commercial test that we can send out for. There are several companies that will run those panels. And that's new. 10 years ago, those were only tests that were done in research labs. And then there are some other genetic and metabolic diseases. Patients with muscular dystrophy, besides having abnormalities of the muscles in their skeleton, also wind up with problems with their heart muscle as well. So what do we do? How do we treat this? And I wish we had really great, wonderful treatments. I wish I could show you slides like Bobby did of great pieces of equipment and little nanobots that we can send down into the heart to make things better. But unfortunately, the kinds of treatments that we have for heart failure are not necessarily dramatically that much better than the ones that we had 20 years ago. We've come to incremental improvements, but we can't repair a heart that's been damaged. We can only help a heart that's been damaged to pump more efficiently. We use drugs called diuretics to get rid of the extra fluid that happens, that the body takes on when the heart's not pumping well. There are a number of agents that are called positive inotropic agents. These are medicines which mimic the body's own adrenaline and other hormones that stimulate the heart to beat stronger and can be used temporarily to improve the function of the heart. Although when you give a patient those medicines for a long period of time, they can actually be detrimental. We'll talk a little bit about afterload reducing agents, beta blockers. Patients who have poor heart function are at risk for developing blood clots in the heart, and those can break off and cause stroke. So patients need to be treated with a blood thinner, an anticoagulant. And then because of the scar in the heart, they are at increased risk of having abnormal heart rhythms, and so we often have to use antiarrhythmic drugs. Diuretics have been around for probably 200 years. Many naturally occurring substances, even caffeine is a natural diuretic. And they work at different parts of the kidney, and they basically help to exchange one ion for another. Usually they get rid of sodium, and then the water goes with it, and they help to reduce the amount of fluid in the body. So you have that patient whose x-ray I showed you with all the fluid in the lungs. A diuretic is going to help that person feel considerably better, but it doesn't deal with the primary heart disease. It only helps the body to adapt better. Anybody recognize this plant? Okay, foxglove digitalis. And so the digitalis was recognized, probably by people living out in the forest a long time before modern medicine recognized its beneficial properties. But there's actually an interesting story about actually the person who may have first described, or one of the first people to describe its beneficial effects, was a young man named Charles Darwin. But not the Charles Darwin who we think of as the origin of species, but his uncle, who was actually unfortunately died at a very young age in his early 20s. But he and his father, Erasmus Darwin, who was Darwin's grandfather, actually were also botanists and were interested in different properties. Digoxin was derived from foxglove. And essentially works to increase the amount of calcium inside the cell and to improve the contraction of the muscle. But digoxin has fallen out of favor as a heart failure treatment these days because it has some toxicities. It's not necessarily well tolerated. But again, it doesn't repair the muscle. It doesn't make anything any better. One of the biggest improvements in heart failure survival came about back in the late 1980s with the recognition that a class of drugs called afterload reducing agents could dramatically improve the function of the heart. And so what are these agents? They're essentially medicines that reduce your blood pressure. And at the time that this was conceived, it was met with a lot of skepticism because patients with heart failure often had low blood pressure. And so people were saying, how could you possibly give an agent that reduces blood pressure to someone whose blood pressure is already low in the first place? But when your heart's not working, one of the things that happens is that your body essentially tries to squeeze down on most of the blood vessels in many parts of the body to reduce the amount of tissue that the heart needs to send blood to. So patients who are in shock, for example, will have very cold skin, and their intestines will shut down, their kidneys won't work, because the body is essentially preserving blood flow to the core, to the brain and to the heart, and basically shutting down flow to the other organs. Well, heart failure is a sort of mild form of cardiogenic shock. And in those situations, the blood vessels in the body are constricting in order to reduce the idea is that they're trying to reduce the amount of blood that has to go to places that you don't need it. However, what that does is it makes it harder for the heart to pump. Because you imagine trying to pump liquid through a tube that's this big versus trying to pump liquid through a tube that's a lot bigger. And so essentially by using these medicines which lower the blood pressure, we call that lowering the load or the afterload on the heart, you can improve the function of the heart, and the patient's blood pressure actually doesn't even go down. And using one of these drugs called enalapril, essentially this study showed a pretty dramatic reduction this is patients dying at the end of a year from 60% rate down to about 40% rate with just this addition of this simple drug. More recently, as we talked about previously, beta blockers have come into use, and interestingly enough, were met with the same degree of skepticism amongst physicians, because beta blockers block the action of adrenaline on the heart. Adrenaline is there to make the heart beat stronger, and everybody argued that why would you want to stop that process? Well, it turns out that in fact that process is dangerous for the heart. It actually destroys, kills muscle cells in the heart, and by blocking the effect of the hormones that are helping to support heart function temporarily, you can get a fairly substantial improvement. So the red bars here are reduction in mortality. These are 5 different large clinical trials, and there have been many, many other clinical trials now with thousands of patients, and they have basically shown that beta blockers, whichever particular class you want to use, this is a particular drug called carvedilol, but there are many others. They all reduce mortality and they improve symptoms, but they don't fix the heart. They don't make the muscle any better. So the only way to fix the heart then that we know of today is to replace it. And so a patient with bad enough heart failure for whom these therapies are not effective, they're put on the list and they undergo heart transplantation. And this is just a sample of the number of heart transplants done each year in the United States. Way back when essentially Norm Shumway was one of the only people doing transplants here at Stanford, there has been an enormous growth in the number of procedures. So there are about 3,500 adults and about 350 kids each year in the United States who have a heart transplant. But I told you there were how many? Thousands, 600,000 new cases of heart failure. Now, not all those patients need a heart transplant, but if 50% of those patients, or 300,000 of them, are going to be dead in 5 years, and 20% of them are going to be dead in 1 year, then at least 120,000, 130,000 people could benefit from a heart transplant, and yet we only have donors available for about 3,500. So this is, even if heart transplant were a perfect option and patients could walk out of my office and say, I never need to see you again, doc, we don't have enough of these organs to go around. There are now mechanical support devices. I showed you pictures of them at the first lecture that can replace the heart pretty effectively, but they're not yet perfected, and it may be many years before those devices are ready to be thought of as a substitute for the heart for someone's lifetime. So that leaves us again the conundrum, and a great way to introduce Joe is, wouldn't it be nice if we could repair the damaged heart, if we could either make new heart muscle cells by introducing a cell type into the heart that makes more muscle, or by somehow coaxing the heart's own cells to divide and make more muscle cells. So that's the problem, and it's easy. And some people think it's really easy until you get down to the last step. And so I think Joe will be here to tell you a little bit about the miracle. We're going to get the microphone replaced. We'll take a few-minute break. But in the meantime, before we do that, are there any questions about what we've talked about in the last half hour?
What percentage of these are due to coronary artery disease as opposed to any other sources you mentioned?
It depends on the age group you're talking about. In adults, it's probably 60 to 80% due to coronary disease. And the reason why those numbers vary is because there are often multiple etiologies. So an adult who has bad coronary disease often has comorbidities like diabetes. And so the combination of the two. But if you look at the large heart failure studies that have been done in the adult population, the vast majority of them are due to ischemic heart disease or some form of coronary artery disease. Whereas in my area, my field, that is an extremely rare situation in kids, and we tend to see more genetic diseases, and we tend to see more viruses causing heart failure. My guess is that the genetic causes are more important even in the adult world, but we're just not recognizing enough of them. And there are actually a couple of studies which have now shown that if you look hard enough by doing echocardiograms on family members of adults who were initially diagnosed with what they call idiopathic cardiomyopathy, that is, we don't really know what the cause is, a lot of them will show multiple family members with milder forms of the disease, and therefore there is probably a gene there, but we may not yet have discovered what that gene was.
Cardiomyopathy, whether it's hypertrophic or dilatory, is it primarily a disease of left ventricle? Or?
So the question is hypertrophic cardiomyopathy primarily a disease of the left ventricle? Interesting enough, in most adults it is. But there is a condition in young infants, usually newborns, where it actually affects both sides of the heart and can be even more severe on the right than the left. That is very rare in adults. Even in older kids, it's a rare condition. So it tends to affect the left side of the heart more than the right. Now, again, as I think we talked about a couple weeks ago, the primitive cells that form the heart actually are slightly different on the left side versus the right side. So if you have a gene defect, every cell in the body obviously has that gene defect. So the right ventricular cells have it as well as the left, but whether or not they have other cofactors that are turned on or turned off, or whether or not it's because the pressure that the heart has to pump against is so different. The left ventricle has to pump against the pressure of the body, or about 120 millimeters of mercury. The right ventricle only has to pump blood against the pressure in the lungs, about a sixth of that pressure. So that may be responsible for some of those differences.
So having a heart attack is sort of the obvious place for someone to get into the hospital, see a doctor, and realize that they're partway down the road to heart failure. How frequent or easy or reasonable is it for someone to be diagnosed much earlier in that catastrophic event and thereby try to do something before they're very far down that road?
You know, I don't know fully the data on that in adult patients, because again, my practice is in kids. But again, what we tend to see is a history of symptoms that has been going on for a fairly long period of time that have been treated or thought of by either the family or their physician as something else. So someone is not able to run as fast or far as they used to. It's because you gain weight, or you're out of shape, or you have a little bit of mild exercise-induced asthma. Kids often present with abdominal symptoms. They don't eat. They feel a little nauseous as their primary symptom of heart failure, especially young adolescents. And we've had kids who've been sent to us by other doctors for evaluation for a liver transplant. We had one young man who came in, sent in by another center for a liver transplant, when in fact it was heart that wasn't working and the blood was just backing up and causing his liver to be enlarged. So because these are rare conditions in kids, at least, they're not necessarily recognized. In adults, again, the symptoms can overlap a lot of other conditions. I think people who are screened for high-risk patients with strong family history, patients with high cholesterol, elevated lipids, patients who smoke, patients who are overweight. Those can help identify risks, and then a treadmill exercise study, EKG, and of course an echocardiogram can pick up myopathies. But we've seen families where one family member comes in and is really sick, and then we will do an echocardiogram on mom and dad, and dad's 60 years old, and he has a mild form of the disease. So the family carries the same gene, but yet that same genetic defect can manifest itself very differently at different ages. Okay, maybe one or two more questions.
How do you determine the extent of scarring in the heart muscle, preferably without having to take a cross-section?
That's a good question. Actually, I probably could let Joe answer that question because that's one of his areas of expertise. MRI is actually a very good way of looking at the area of scar. There are some simple ways with ultrasound that we can, because since scar doesn't contract, if you see a part of the heart muscle that isn't beating very well, we can stimulate the heart either by exercising the patient or by giving them a medicine which increases the heart rate called dobutamine or dopamine. When we do that, we can see part of the heart that doesn't work very well. That suggests it's scar muscle, but scar tissue. But there is a test that can be done with an MRI that can actually show scar with pretty good accuracy. Okay, last question.
When I first tried orthodontics, I think about 35 years ago, the first thing the pediatrician told me to put in my medicine cabinet was ipecac, and I find it on your list of toxins.
Only if you abuse it. So ipecac is a medicine that's taken if you have an overdose to induce vomiting. And so one dose of ipecac isn't going to hurt anybody. But in patients with bulimia, eating disorder, who induce themselves to vomit, they may take ipecac daily. And if they are abusive of ipecac, it can cause a problem with heart muscle, it can cause a cardiomyopathy. Okay, there's one last one in the back.
When you're considering a heart transplant, what does the age difference have to be or should be between the donor and the recipient?
Doesn't really make a difference. It's the size. So we list people by their blood type and by their size. So we like a heart to be somewhere between 90% and about 150, 160% of the recipient's weight. The one exception to that is that teenagers seem not to do as well when they have a donor that's over age 40. They seem to do worse. So if I put a 40-year-old heart into a 30-year-old, they do well. But when I put it into a teenager, the mortality is much higher, and therefore there's a special exemption on the listing status for teenagers. And if there's a teenage donor available, they get the heart preferentially goes to a teenager if there's a teenager waiting on the waiting list. But other than that, it's not so much age. Although, if you're a 30-year-old and there was a donor who was 60, you wouldn't necessarily want that heart. And in fact, it's very rare that we use donors that are that old. Most donors are younger people, and they're doing the kinds of things that younger people do, unfortunately, to wind up becoming donors, like riding motorcycles without a helmet and things like that.
I think it's a hard, tough act to follow Dan. I've known Dan for a while. He's an outstanding speaker. I'm going to talk about stem cells. This is what we do in our lab, and I think it might be a little bit difficult because a lot of the stuff that we do is very, very technical. So I'm trying as best as I can to narrow this down to very, very simple so that you guys could understand what we're trying to do to address this question of whether stem cells can be used for cardiac regeneration. I think I like to keep this as informal as possible so that if you have any questions while I'm trying to explain some concepts, just feel free to raise your hands and then I'll take the questions. And I think it's better that way because otherwise I think halfway through my lecture, about half of you guys will be asleep already. So I'm going to talk about a little bit of background, and I'm going to talk about adult stem cells, embryonic stem cells, induced pluripotent stem cells. So by the time I'm done here, you should be able to go home and tell your significant other, tell your friends what the difference is between adult stem cell, embryonic stem cells, and induced pluripotent stem cells. And I'm going to talk to you how, despite what the lay press is trying to tell you about how exciting this field is, I'm going to talk to you about some of the problems and challenges that we're working in the lab, and some of the research projects that we're trying to address these challenges. So I think Dan mentioned about this. This is a schematic of a heart, and this is a coronary artery right here. And basically, I'm an adult cardiologist, so I see these patients in which they come into the emergency room. Basically, the blood artery right here is blocked. There's no blood perfusion to the heart, and the whole heart right here dies off. And then afterwards, the heart balloons out. And then later on, they can have remodel of the heart so that you see the shape of this heart is much bigger than this heart right here. So the idea of stem cells is then that why not just inject some stem cells, and hopefully the stem cells can form new blood vessels at this state right here, can prevent some of the cells from dying, can prevent some, decrease the amount of toxic chemicals that occurs after a heart attack. And then the other idea is that for the stem cells, is it possible that these stem cells can replace some of the lost cardiomyocytes right here? And there are several techniques to isolate the stem cells. There are stem cells from your blood, stem cells from your bone marrow, stem cells from your skeletal myoblasts, stem cells from your fat, embryonic stem cells, different ways of delivering the stem cells, and different ways of isolating the stem cells, and different ways of injecting the stem cells. So this is very, very complicated here, but I'll try to narrow this down and basically make it simple for you guys to understand. So what are adult stem cells? Adult stem cells share two characteristics. They can make identical copies of themselves, so they can self-renew. They can also give rise to mature cell types that have specialized functions. All of us in this room have adult stem cells, all of us, right? So for example, your red blood cell only lasts about 120 days. So if you do the math, in each day, your body is generating about 1% of the red blood cells, right? Likewise, your skin turns over every 28 days, and your small intestinal epithelium turns over every 3 to 5 days. So, every week, every 3 to 5 days, in your gut, there's new stem cells, and these stem cells are giving rise to these intestinal epithelial cells right here. So all of us have adult stem cells, right? Everybody in this room. So adult stem cells are, for example, bone marrow cells. You've heard of bone marrow cell transplantation. You can take these bone marrow cells to do transplantation into different organs. And in fact, this is a very complicated slide. In fact, it's based on this bone marrow cell transplantation where this first study was done. So we're talking about cardiovascular stem cell therapy. Back in 2001, right here, there was a group in New York that basically demonstrated in a mouse model. They took bone marrow cells from a mouse and injected it into another mouse that has heart attack. And then about 10 days later, they showed that a lot of this heart right here from the heart attack mouse are green. And because the green cells came from the donor cells, they basically made the observations that the bone marrow cells must be giving rise to the heart cells. So imagine this possibility, taking bone marrow cells, inject into a patient with heart attack, and these bone marrow cells will give rise to cardiac cells. So we cardiologists are not the smartest specialists out there. So by 2002, which is exactly 1 year later, we are already injecting bone marrow cells into patients with heart attack. So these are patients, luckily this is a study done in Germany, not in the States, but we have some trials going on in the States right now. So basically these are patients who come in with heart attack. The physicians go into the long femur or go to the iliac crest right here, suck out the bone marrow, and then inject the stem cells back into the same patient. And the idea back then was that maybe these bone marrow cells became cardiac cells, and therefore you could rescue the cardiac cells. So by 2006, we are we were already doing these large randomized clinical trials. And basically, these are published in the New England Journal of Medicine, taking patients' bone marrow cells and inject them into acute myocardial infarction settings, acute myocardial and different kind of stem cells. These are bone marrow-derived cells. These are endothelial progenitor cells right here. But if you look at the data is actually quite controversial so far. So let's say, for example, these are 1, 2, 3, 4, 5. These are 5 trials listed right here. And one of the trial right here, for example, it says what? At 6 months, there's no significant difference between the two groups, meaning that the patients who had heart attack and conventional therapy versus the patient who had heart attack and bone marrow cells. Another trial shows that at 4 months, there's a slight improvement, but then at 1 year, there's no improvement. And so from a researcher standpoint like us, we're very interested in figuring out why is it that there's this kind of discrepancy. And so the issues that were raised in clinical trials are, what is the best cell type you want to give to a patient? When is the ideal timing for cell transplant after a patient gets a heart attack? Patient comes in with a heart attack. Should he give the cells immediately, or should he wait for 7 days, a couple of weeks later and give the cells? How long do these cells survive after you give to the patient? And do these cells integrate into the heart? And then how do you monitor these cell fate? So again, you have to think about it from a researcher's standpoint. If you want to address these questions, how would you address these questions?
Do we expect bone marrow cells to give rise to other than red blood cells?
Well, that's very controversial, right? So I think the question is, do you expect the bone marrow cells to give rise to cardiac cells, right? So that's very controversial. That was based on that study in 2001, showing that in a mouse model, if you inject bone marrow cells, it can give rise to cardiac cells. And by 2002, cardiologists were already injecting this into patients, thinking that wouldn't it be nice if bone marrow cells give rise to cardiac cells? But the story is it's actually not true. It doesn't work that way. And I'll show you some examples of what we're trying to do to simulate that. But the question I pose is, how would you study this? How would you study what happened to the bone marrow cells after you give to the patient? How would you study what happened to the progenitor cells or any kind of stem cells? So we go back to the lab and we take advantage of some of the toys and technologies that we have at Stanford. This is all the different kind of imaging modalities that we have at the molecular imaging program at Stanford. And what we do is basically ask a very simple question. In clinical trials, physicians have injected bone marrow cells, skeletal myoblasts, mesenchymal cells, and other stem cells into patients with heart attack, right? We want to know what the difference is among these cell types in animal models. Again, I'm a researcher. I'm trying to figure out how this thing works. So we basically came up with this mouse right here, and this is an amazing mouse right here. This is a mouse that glows green here. The whole body glows green color. And the whole body also has some glows with luciferase. This is a luciferase. It's basically the same kind of light that you see in firefly luciferase, basically the fireflies that you see in summer camps. You basically take that gene from a firefly, put it into a mouse. The whole mouse glows with light. And what you can do is take these stem cells from this mouse and put it into a sister mouse that has no that has no color in it. So I can image what happened to the light, and I can tell you what happened to the stem cells, right? So this is a way of how scientists think about how do you address clinical questions. So let me show you this data here. So let's say, for example, this is a mouse and injected with bone marrow cells, and you can track the same animal at over 4 weeks. So this is day 2, day 4, week 1, week 2, week 4. Another animal injected with another stem cell that we use in clinic. Another animal injected with mesenchymal stem cells. Another animal injected with fibroblasts. So let me ask you, if I take in an animal model to simulate clinical trial that using mesenchymal stem cell, if I inject mesenchymal stem cell into this animal, At day 2, there's good signal. The cells are alive. What happens at week 4? It's going away. So what does that mean? They're dying. The cells are dying. Now, if they have become cardiac cell, it would have stayed there, right? The signal would have stayed there flat. But the fact that you're seeing the signal goes down tells you the cells are dying. Good. So I like the progress so far. So you guys are following me right now. This is very good. So in clinical trials, physicians have infused bone marrow cells peripherally, meaning that patient comes in with a heart attack. We just inject the bone marrow cells into their arm. And then, so we want to know what happens to these bone marrow cells. So patient comes in, you inject the stem cells into the arm. Do the cells go to the heart, or maybe do the cells just go elsewhere? How much of the cells go to the heart? Do they stay in the heart? So these are the questions that nobody knows. And therefore, you can go back and you ask this question, you go back to the lab, and you try to simulate this. So this is an animal that has a heart attack. Basically, we crack open the chest, we create a heart attack, and we inject the cells by tail vein, right? And then you can see the same animal at day 1, day 2, day 4, day 6, day 8, 10, 14, 21, 28. So my first question is, when does the peak homing of the cells to the heart occur? Around this time period, right? The peak homing, right? What happened to the cells after 1 month? It's gone. So in clinical trials, I can go back and I can tell you that the trials that use these kind of stem cells injected into the patient, the physicians have no idea what happened to the cells. But in an animal model, you could tell them that most likely, you know what, by about 4 to 6 weeks, your cells are gone. So these bone marrow cells that you're injecting that you're hoping to become cardiac cells, they're not becoming cardiac cells, they're all dying. And then the third question is, for example, in clinical trials, physicians have injected stem cells into patients with acute heart attack, as well as chronic myocardial ischemia. This is a model that Dan told you about. Some patients have chronic heart problems. And the question is, we want to know if there's a difference in cell survival between these two conditions. I guess the simpler way to put it is a lot of times the patient comes in with heart attack, and we kind of debate over, should we give the cells immediately to the patient, or should we wait for 2 to 3 weeks and give the cells to the patient? The idea is that if you give the cells immediately to the patient, and because of the heart attack, it's very, very inflamed, very, very hot, quote unquote, and the inflammation can kill the cells. And maybe it's better you wait for 2 to 3 weeks, have the patient cool off, and give the cells. Or does it make a difference? So what would you guys think? I mean, who would want to give the cells immediately after the heart attack? Immediately, okay, so let me show you the data. So this is an animal simulation of cells that are given immediately after the heart attack, acute myocardial infarction. This is a simulation of an animal that was given 1 week after the heart attack. And you can see immediately after the heart attack, because of the inflammatory response, it stimulates some cells to proliferate. And therefore, you see the signals that are higher than this one. But what happens at day 42? No difference. It doesn't matter whether you give it acutely or after a long period of time. So what is the major hurdle of adult stem cells so far? Cell death. What is the second major hurdle? Immune response, possibly. We don't know yet because you're taking it from the same patient, right? So you're taking the bone marrow cell from that patient, do a very, very short-term process, and inject it back into the same patient. Probably not that much at this point. Second problem is cell death. What is the third problem? Cell death, exactly. Cell death, cell death, cell death. These cells are dying. These cells are not becoming heart cells. If it's heart cells, the signal will stay there for a long period of time, and you will see it. So this gets to the point, the second cell type, which is embryonic stem cells. So how many of you knows what embryonic stem cells are? Okay, so embryonic stem cells are derived from fertilized embryos. They have self-renewal properties, but unlike adult stem cell, they can self-renew, but for some of them, they poop out after a while. For the embryonic stem cell, they have basically unlimited self-renewal. They can keep on renewing. Adult stem cells can only become a certain lineage, meaning the bone marrow cells can become lymphocytes, white blood cell, red blood cell, and some other cells. The bone marrow cell cannot all of a sudden become brain cell. The ES cells have this ability, and that's why they are called pluripotent. They're able to do that. So where do you get the ES cells from? Embryonic stem cells. It's an egg fertilized by a sperm, and it divides 2 cell states, 8 cell states, and 32, and then after a couple weeks, it becomes this trophoblast. And basically, we just isolate this area right here and grow these as cells. If you didn't isolate this area, if you just let it go this way, it basically will become you, right? You'll become a heart, you'll become a brain, you'll just become a person. So the question is, do you have embryonic stem cells in your body anymore? No, we don't have them. We have adult stem cell, but we don't have embryonic stem cell. Now, embryonic stem cells can, again, you don't have to know this, but the idea is that it can give rise to pretty much all parts of your body. And that's the beauty of an embryonic stem cell. This was discovered back around 1998 by Jamie Thompson at University of Wisconsin. And I'm not sure if you're aware, but so this is 2010. So 2010, in Geron Corporation, which is a company located in Menlo Park, about 10 minutes from here, is already starting these human embryonic stem cell derived oligodendrocytes into patients with acute spinal cord injury. Right? So patients comes in, acute spinal cord injury, inject these cells, and see what happens. Now the question, there's a lot of debate among the scientific community as to whether this is the right approach or not, because there are a lot of issues that you need to work out. These embryonic stem cells are pluripotent, right? So what happens if some of these cells decide to become a heart cell? What happens if some of these cells decide to become a bone cell and you inject into patients a spinal cord? So you have to figure out that you need to purify the cells very well. And these cells can proliferate, and if it's not checked, they can become a tumor, right? And these cells came from somebody else. So you gotta immunosuppress this patient because the patient's gonna reject the cells. So there are a lot of issues that still need to be worked out. But in our lab, we're interested in basically, this is an example of embryonic stem cells, and then after about 3 weeks of culturing, you can see these ES cells basically becoming beating cardiomyocytes. And we're very excited in terms of thinking about how do you take these beating cardiomyocytes and inject into patients with heart disease. Now, let me give you some background about embryonic stem cells and try to kind of help you understand why there's so much controversy about embryonic stem cells before we shift to the iPS cells. So the embryonic stem cells, as I told you earlier, are derived from the eggs that have been fertilized by sperms in IVF clinic. That's it, IVF clinic. And then these cells are then donated to researchers with the informed consent of the donors, okay? Now, as you know, the first test tube baby occurred back in 1978. The person who invented this technique, Robert Edwards, received the Nobel Prize in Physiology for pioneering IVF. Okay, so what happens with basically a couple that can't conceive? They go to the IVF, go to the Stanford IVF clinic, and the physician gives the wife some drug, and the woman super ovulates and has 30 eggs at a time, fertilizes with the sperm, and then afterwards the couple was able to successfully conceive. What happens to these leftover embryos? Well, there are 4 options. One is to discard them, or you just get rid of them. And 2 is that the couple can pay hundreds of dollars to keep them. And then 3 is that you can give to other couples. I think for a lot of personal reasons, some couples are not willing to do that. and then 4 is basically donated to medical research. So most of the embryonic stem cells in the States are basically the couples with leftover embryos decide to donate to medical research. Are embryonic stem cells derived from eggs fertilized in a woman's body? No, because we don't go into a woman's body to extract the fertilized egg. In fact, those are no longer embryonic stem cells anymore. So let me just give you this myth right here. So, a lot of people think that people who work with embryonic stem cell uses aborted fetuses. There's actually no connection between abortion and human ear cell. By the time a human embryo has implanted in the uterus, its cells have started to kind of transform into other cell types, into brain, into some other cell types. So we can no longer use them to derive embryonic stem cell lines. And then basically the embryos that are used to derive the lines are created in dishes in the IVF clinic that I kind of explained to you earlier. And then they're never transferred into the body and things like that. So, but why so much controversy? I think it's just, I think as you know, there's this question of destroying human life, and it basically depends on how you define human life. If human life starts at day 0 or versus human life starts later. And my point is that, again, when does human life begin? There's no right or wrong answers here. And I just want to emphasize this. Again, there's no right or wrong answers here. But if you can go home with this concept right here, that the cells that we use for embryonic stem cell basically came from here, leftover embryos. The couples have 4 options, discard them. We're telling them, instead of discarding them, why don't you donate it to medical research so we can study about them? That's what we're trying to do here. And I think, as you know, in the States, it's very, very controversial. This is a lawsuit that happened a couple years ago, challenging embryonic stem cell research, because we do embryonic stem cell for about, I guess for about 2 weeks, we were affected because our funding was stopped because of this lawsuit. But then, the federal government challenged the lawsuit, and this has been lifted here. And then more recently, this is just last week, there's also this, I'm not sure if you heard of this, but the European court bans patents based on embryonic stem cell research. So a very, very controversial area. Any questions so far on this before we shift? So when you go home, we don't have embryonic stem cells in our body. Embryonic stem cells are not derived from a woman's womb. Embryonic stem cells are mostly derived from fertilized eggs in vitro fertilization clinic, and the patients have given their consent for medical research. Yeah.
You showed a slide of eating
yes.
Embryonic stem cells.
Yeah.
Are you going to explain how you got that to happen?
Oh, you have to work in the lab for me to show you that. There's a lot of technical procedures that I don't want to bore you with, but it takes us about 21 days to make an embryonic stem cell into a heart cell. We focus on the heart. There are a lot of investigators across the country, across the globe, that are interested in making embryonic stem cell into brain, into kidney, into other organs. But for the heart, it takes us about 21 days, adding this, adding that, different kinds of growth factors to simulate, these growth factors to simulate the in vivo development of a heart. And basically, a lot of trials and errors and a lot of tribulations and, to get to that step. What
chemicals that you add?
Chemicals, exactly. Yeah. So this gets to the concept of this iPSC. There's a lot of ethical debates, a lot of political debates on this. And then I want to shift gear to iPS cells. So what are iPS cells? So back in 2007, there's a group in Japan, Shinya Yamanaka, found out in a mouse model and followed by a human model here, showing that if you take a skin from a patient and you add certain factors right here, you can turn the skin into something called induced pluripotent stem cell, which is very, very similar to embryonic stem cell. And then you can take these cells, just like I told you earlier, make it into cardiac cells, You can use it to treat the patient. You can use the cardiac cells to do drug screening. You can do it for genetic screening, right? So this is perfect. You avoid this issue of destroying an embryo. I go in, take a skin biopsy, add a few genes right here, make your skin into embryonic stem cell-like, and then I can differentiate your skin into whatever cells you want. So this is, this is quite amazing in terms of how this procedure works. So in our lab, we're interested in using these iPS cells for drug screening and for gene correction and for regenerative medicine. And the idea is that, a lot of times when you take medicines, for example, heart medications, sometimes you take this medication for a while and you go back to the doc and say, hey, doc, this medication is not doing anything for me. I don't feel any improvement. Whereas another patient has good improvement with this particular medication. So when you think about medicine 20 or 30 years down the road, there are some physicians who are thinking, why not take your skin and make it into iPS cell and make it into heart cell, and I expose your heart cell to all these drugs you're taking, and I can, instead of you being the guinea pig, your cells become the guinea pig, and I can tell you, which drug you're going to respond to. Right? Now, that's thinking outside of the box, right? That's really thinking outside of the box. Forward-thinking medicine, in 30, 40 years from now. Instead of you be the guinea pig, I take your skin, have your skin cell become the guinea pig for these drugs. And I'll show you examples of what we're trying to do. So this is a patient. We started with a dilated cardiomyopathy patient. This is a patient, that, as you can see, very similar to Dan's patient. The heart is not squeezing. We took the patient's blood, and we do whole exome sequencing of the blood. And we found that there's a mutation in this patient. This patient has a troponin mutation, so the heart is not squeezing. And this is him right here. And it turns out his brother also has a disease. His mother has a disease. One of his sons also has a disease. It's a large family with dilated cardiomyopathy. Heart is not squeezing. So me being the curious physician scientist, I say, okay, why not come in and we do a skin biopsy on everybody in your family? And we did. We skin biopsied the whole family tree and take the skin, make iPS cell, and then make heart cell, right? And this is an example of one of the patient's heart cell. I'm not sure if you can see it, but you can see this beating right here. And we can measure the EKG on a cell. Okay, so this is an EKG from somebody with dilated cardiomyopathy. This is EKG from a normal patient. And then we can challenge this patient's cell with a drug called norepinephrine. Norepinephrine is a drug we give to patients in a clinic, in a hospital. If a patient is not doing well and has low blood pressure, we oftentimes give the norepinephrine to boost the blood pressure up. But we can't give it for a long period of time because the drug is toxic. And so for normal patient, it's fine. We can tolerate the norepinephrine. But for somebody who's very, very dilated, the norepinephrine causes the heart to squeeze like this. But after a while, the heart can't tolerate it, just poops out. And you see this happening in a control patient, meaning that when we give the norepinephrine, the heart rate goes up, it stays up. In a dilated patient, I take his skin, make the heart cell, I give the norepinephrine, the heart rate goes up, and what happens? Comes down. It's pooping out, reflecting what we would have anticipated had this patient gone to the hospital, CCU, given the norepinephrine. This thing would have happened inevitably. And you can see the cells. These are cardiac cells from that patient. Now think about this. These days right now, how do I get cardiac cells from you guys? I have to go in and do a biopsy of your heart, and that's very, very invasive. And if I tell the patient that which one of you guys would like to volunteer and give me a heart cell, I don't think any one of you guys would raise your hands, right? But if I say, which one of you would like to donate some blood so I could turn your blood, or donate some skin, I can turn your blood, your skin into iPS cells, and then into heart cell, and I can study them and help you figure out which drug you want to take. I think a lot of you raise your hands. And this is what we're trying to do. So this is a patient that has normal patient. You give the epinephrine, nothing happens. The patient that I told you earlier that has the ultrasound showing poor contractility, you get no epinephrine, and basically all the proteins, this is what we call the sarcomere, all the proteins are breaking apart. You can see this, this disintegration of the proteins right here. I would never be able to demonstrate this in a patient because I have to go into the skin biopsy. Do the heart biopsy, but I can demonstrate this right now in the patient. So the other thing we can do, I'll quickly explain this, but the other thing we can do is we can do something called a zinc finger nuclease, and we can correct the mutation. We can go in, we know where the mutation is. Mutation is at exon 12, and we can go in with another construct and swap out the mutation. And that's basically a gene correction of these cells, so that the cells that we get now no longer has the mutation, and they'll be fine. And this is what a lot of people, including our group, is trying to do, is basically genetically modify those cells so that you have the mutation.
Exon 12 is a gene?
It's exon 12 is within a gene. So let's say, for example, in chromosome 1 or chromosome 2, there will be a lot of exons, and exons are the ones that comes out of the cell and it gets translated. So this is part of the gene, and this mutation, TNNT2, happens to occur at exon 12. And we basically genetically modify the cell to swap out that mutation, put a new copy of the gene in. And the idea is that, and I didn't want to show this, but the idea is that now this guy's heart cell no longer has the mutation. And that's what we're trying to do. So when you think about this, how do we run clinical trial? We run clinical trial by coming up with a drug X, and we give it to, 5,000 patients, 2,000 without the drug, 3,000 with the drug. So what the forward thinking is that instead of doing on a patient, which is very slow and costly, we can just do it on the 5,000 cell lines from 5,000 different patients, and repeat the same process again. And that's what we're trying to do in our lab. We're creating all these lines right here. These are the lines that we created in our lab. And we basically created more than 100 lines from 50 individuals, age range from fetus to 77 years old, different reprogramming techniques. And we have patients that have dilated cardiomyopathy, patients that have hypertrophic cardiomyopathy that Dr. Bernstein talked about, patients that have long QT, and healthy volunteers. And we're always looking for volunteers with interesting phenotypes, even those in this audience here. Very simple. We actually pay you $100 to show up to get a skin biopsy, so that's an extra incentive. Very simple procedure. So the last part of my talk is going to be this area. So a lot of people say, why not just take human iPS cells? Because you take your skin, make iPS cell, differentiate the cardiac cell right here, and inject back into the same patient. Right? Voila. This would be perfect, right? So how many of you think this step takes, a couple years to achieve, or is it going to take, I guess the question is, what are the steps that are necessary to validate each one of these steps that are necessary to push it into clinical trial? It's actually very, very cumbersome, because when you think about it, I can't just take this and put it back into you. I have to figure out, is it going to be your skin cell? Or should I take your fat cell, turn it into iPS cell, and put it back into you? Or should I take a heart cell, make it into iPS cell, and put it back into you? So I have to figure that out. I have to figure out that how do you make these iPS cells. I have to make sure that these cells can all become cardiac cell, and the cells I give you is all cardiac cell instead of, I don't want to inject brain cell in this population into your heart, right? And I want to make sure that the cells I give you don't become a tumor as well. And I want to make sure that the cells I give you also has the ability to engraft and to show efficacy not in the mouse model, but also in the pig model. This is what the Food and Drug Administration would ask you, 2 different models. They just don't, they don't want to show that there's an improvement in function in the mouse, but they want to show it in something that's more physiologically similar to humans. So this is easy. This is what everybody's talking about. Let's just take this, make it heart inject. But this is what's giving me the gray hair right here, because we have to figure all this out. The scientists have to do it. And I think the lay public thinks of this, but in fact, there's a lot of this kind of stuff that goes on to figure out what is the best. And you probably want somebody to figure these things out. You probably don't want people to oversell this and say, oh yeah, I can just take this and put it back into you, because that's not going to work. So let me just quickly run over some concepts. So there are different ways to make iPS cells. You can use lentivirus, retrovirus. You can use viral technique, or you can use non-viral technique. In our lab, we work with a non-viral technique because this is safer for clinical translation of the iPS cells. So you have to figure out how do you transfect the cells. Now, let me give you a story. So how do you think Yamanaka, back in 2007, discovered that you can turn the skin back into an embryonic stem cell? So it's actually a very simple idea that he had. So if you take a skin and you take an embryonic stem cell, and there's a technology called gene expression array, you can basically figure out what are the genes that are expressed here versus the genes that are expressed here. And he figured out that the genes that are expressed very, very, very high here in the embryonic stem cell must somehow be contributing to the cell becoming embryonic stem cell. So he basically asked his postdoc and say, show me those 100 genes. And he asked his postdoc to take those 100 genes and transfect your skin cell one by one to see which one of those genes can push the skin cell back into iPS cell. And he basically came up with a whole bunch of experiments and came up with that combination of 4 genes. By adding four genes that are present in the embryonic stem cell, you can turn the skin back into a embryonic stem cell-like. You have a question?
What does the word transfection mean?
Transfection just means that you have a cell, and you need to put the gene inside the cell. And the cell is going to have a physical barrier. It's going to prevent whatever that gets in. So you need to have some kind of vector that carries the gene in. So you could cheat a little bit by using nature's vector. So nature has come up with adenovirus, right? You get a cold. When you get a cold, a lot of times people with a cold gets adenoviral infection. And basically, the cold virus transfect your cell. You can cheat a little bit by using lentivirus, which is or retrovirus, which is a derivative of HIV. HIV virus take their gene and transfect your cell, and the gene goes inside the cell. But we don't want this in clinical trial. We want something that's simpler. And so getting back to what Yamanaka did, he basically come up with 100 genes and just do one by one, figure out 4 genes that are important, and take these 4 genes and package it into a retrovirus, and then transfect the cell and make iPS cells there. But this is back in 2008. So right now, we're thinking about something that does not require a virus, so that it's safer from the FDA standpoint. Okay, so is that clear? Okay, so the second question is, should we do should we do skin? Can we do other cell types? So when you think about it, initially the studies were done in fibroblasts, but there are other cells that you could do right here. And for the sake of time, I'll just fast forward into adipose stromal cell. So I raised the question, what happens if a patient is skinny and we can't get enough adipose stromal cell? But luckily, that doesn't happen too often here. So we use adipose stromal cells. So patient shows up, the surgeon can just do a small incision and suck out a lot of fat. And we can make your fat into iPS cell and then turn it into heart cell. So wouldn't that be great? I mean, the excess fat that you have, we could turn it into something useful, right? And in fact, the fat cell is easier to reprogram than the skin cell. It's about 20 times higher yield than the skin cell right here. And so we have some notoriety in the sense that a lot of people actually call us up and say, hey, doc, I'm kind of obese. Can I stay obese? Because one day I can use these fat for something good. And we have to explain to them, no, that's not our intention. But the fat cell can be turned into iPS cells as well. So, and then afterwards, once you make them into heart cell, I told you that there's a potential of forming a tumor, right? Because I told you that the iPS cells and the ES cell, by definition, they can keep on self-renew. And they're pluripotent, meaning that it can become any cell type in your body. So what guarantees us that if I'm going to inject 20 million cells into a patient's heart, and these 20 million cells I think are all cardiac cell, what guarantees us that they may be 1, 2, 3 cells that are still undifferentiated and basically has the potential to become other cell type? And then what is the lowest cell number that can cause a tumor in a patient, right? Because one of this happening is going to shut down the whole trial. And this is something that we work very, very hard to try to prevent. And how do you track a tumor, and how do you kill the tumor? So these are the questions that we're thinking about. Let me give you this example. This is a real case example. This is published in 2009. There's a boy in Israel. He had ataxia telangiectasia. It's a medical term. Basically, the boy had balance problems. And he went to Russia. And of course, it's Russia. It's not US, right? So in which the Russian doctors inject a human fetal neural stem cell. Human fetal neural stem cells. And then 4 years later, he started to develop more problems. And the physician scanned the head. And this is an MRI of the head. This is an MRI of the spinal cord. And you can see the tumor right here. And you can see the tumor right here. So you don't want this to happen in your human ESL or human iPSL trial. And we certainly don't want to appear on CNN with our face on and say, things like that. So, and let me give you an example. So in this case here, what we do is we're trying to figure out what is the lowest cell number that could cause a tumor. So you take these cells that has this luciferase, this firefly glow in the dark, and you inject 100 of these cells that are undifferentiated into the heart, 1,000, 10,000, 100,000, 1,000,000. So how many cells, looking at this picture, how many cells is needed? How many undifferentiated cells in a mouse model is needed to cause a tumor? Somewhere here, right? Somewhere in between. Somewhere right here, 10,000, I didn't really see it. But once I get up to this number, I start seeing this signal keep on getting bigger and bigger and bigger and bigger. And the fact that big and bigger means what? The cells are dying or the cells are proliferating? Proliferating. And when you cut the cell, this is what you see. So this is a heart, and you'll see bone, sometimes you'll see hair, sometimes you'll see a whole bunch of junk inside. Okay, so this what happens in a mouse model if you don't be careful with this. So one way we could do is come up with fancy techniques to sort against the cells. So these are fact sorting and figure out what the surface marker of the cell. And basically the idea gets back to what Yamanaka was doing. You take an embryonic stem cell, you take a fibroblast, and on the surface of the embryonic stem cell, they're very different from the surface of a fibroblast. And you basically try to figure out what the surface proteins are, and you say that the cardiac cell I want to inject should not have this surface protein because I don't want the undifferentiated embryonic stem cell to be contaminating my cardiac cell. This is what we're doing, trying to figure out ways, and this is a combination of SSCA5, CD9, CD90. I won't go into this. So this is one approach to sort the cells to make sure these cells are no longer tumorigenic. Another way is once you inject into a patient, figure out how do you detect them before the symptoms show up. So that boy had more symptoms 3 to 4 years later. So you don't want the patient to come back and say, hey, doc, I'm having problem walking, or I feel all these palpitations. So it would be nice to come up with ways to detect them, to image if the tumors are forming. So this is something that we're working on. And basically, the idea is that the tumors have a lot of expression of a protein, something called alpha V beta 3, that's needed for the stem cells to stick together. And we can come up with a probe that binds to the alpha V beta 3, so we can inject into the probe into the animal and show that the tumor lights up. So this is one way to detect where the tumor goes. And then another problem is then how do you induce tolerance? For example, I told you earlier that human embryonic stem cell came from somebody else, right? We don't have human embryonic stem cell in our cell. The research that we do came from an in vitro fertilization clinic, but that ultimately came from somebody else's embryo. So if you take those cells and inject into a patient, you need to immunosuppress the patient, right? So what are the ways that you need to induce tolerance? And this is something that we're interested in. Now, one of you raised this question that with iPS cells, it came from the same person, right? You take the skin, you make iPS cells, and you make it into whatever cell, inject back into the same person. Theoretically, there should be no immune rejection, right? It comes from this same person. But this study right here showed that it is possible that the iPS cell themselves could be immunogenic. Now think about this process. I take your skin, I add some genes into it, I make it into iPS cell, I add a whole bunch of growth factors into it, I make it into cardiac cell, brain cell, I then inject back into your cell. Now think about this process here. Has the immune system in your body, have they seen a cell that has been quote unquote transformed before? They haven't. So it's possible that during this transformation process, the cell itself that's being transformed turns on a whole bunch of new proteins that the immune system in your body, even though it came from your cell, has never seen before, and say, whoa, 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 this guy has been out, in the dark for like 6 months, and it's coming back to me. I don't know what's going on. This one just doesn't look normal to me, and therefore I'm going to reject it. So this is a question that still needs to be addressed, that this iPS cells, whether it's immunoprivileged or you'll get immune rejected. One idea would be just to give the patients with these stem cells immunosuppressive drugs. So my question to you is, how do you know what drugs to give to the patient? So you have a patient that comes in 10 years down the road and gets an ESL, iPS cell-derived cardiac cells. How do I immunosuppress the patient? I can use the same regimen as what we do in heart transplant, but do you know if it works or not? Nobody knows. So you go back to the animal model and you test. So here, you take human embryonic stem cells and you give it to an animal, and you don't treat the animal with any drugs. And day 0, there's a good signal, and day 7, what happens? So basically, the animal is rejecting the human ES cells, right? So you give the animal 3 drugs that we give to patients in the clinic, something called mycophenolate, something called tacrolimus, and sirolimus. Are they very effective in terms of preventing the rejection? No, right? What about here? Combination of tacrolimus, mycophenolate, combination of sirolimus, mycophenolate, combination of tacrolimus, sirolimus. Is it very effective? Not really, yeah. So this is an example of how you could go back to the bench and figure out what drug combination is needed to improve cell survival. So that was back in 2008, and it took us 3 years to come up with a different combination. And this is something called co-stimulatory blockers. And in this case here, we took a human iPS cells, inject into an immunocompetent mouse. And what happens within 7 days? It all rejected. What happens if you take these human iPS cells into an animal that has no immune response, something called severe combined immunodeficiency animal? This animal has no immune response. What happens to the cells? It's proliferating like gangbuster. There's no rejection. What happens when you give the animal, an immunocompetent animal, with this cocktail drug which is, in our experience, a combination of these three drugs, which I won't get into. But your eyes can see just as well as I do what happened to the cells, the proliferate. So this is a much better combination of drugs that's needed to prevent rejection of these cells. And this is something that we're working on with several investigators at Stanford. And then last couple points, there's also this issue of something called epigenetic memory. The idea here is that if I take your skin and make iPS cell and then differentiate to cardiac cell, is it possible that the cardiac cell still has some skin gene in it, right? Likewise, if I take your fat and make iPS cell and differentiate the cardiac cell, is it possible that these cardiac cells still have some fat gene in it? Maybe, and probably yes. And that's what the researchers are finding out. Probably yes, there's still some residual memory, and this is something that we need to work out. Now, it's not always all bad, right? So, I mean, I think a pessimist could say, this iPS cell stuff doesn't work. But you could turn it around by saying that if your disease is heart disease, and I want to make a lot of heart cells for you, I would take a small skin biopsy, small heart biopsy, make iPS cell, and because of the memory, I can get more cardiac cell, right? If your disease is, say, you have some vascular disease, I can take some vascular cell from you, make iPS cells, and give rise to more vascular cell because of this epigenetic memory issue. So the simplest way to explain this would be, let me skip this, would be, let's say, for example, for those of you interested in geography, you want to reprogram San Francisco to Chicago. And I add a whole bunch of factors into it. And we start with the Golden Gate Bridge, right? And then you see the Sears Tower. Voila, I got my Chicago right here because I added a whole bunch of stuff. But then your plane landed in O'Hare, and then when you get out, this is what you see. And that's almost what's going on. On a very subtle level, you're still seeing some, quote unquote, some epigenetic memory. And that's something we need to work on for investigators like us. Another issue is this preclinical model. I told you earlier that the FDA, the Food and Drug Administration, asked us that before we can give this to patients, they want to demonstrate it in another model. So we've been doing this also from a dog and a fat, and from a dog model, and basically just like what we did with humans, we took the dog fat and we added some genes into it and make dog iPS cell. And you can see the dog iPS cells is very, very similar to the dog embryonic stem cell. This is a typical gene expression profile to see how many genes are. The dog iPS cell is very, very different from the dog fat cell where it came from. So we took the dog fat cell, add reprogramming gene, and make it into iPS cell, and make these iPS cells very, very similar to the dog embryonic stem cell. And then we can basically inject these cells back into the dog heart, into the same dog heart. So what we're trying to do here is that we're trying to address the FDA's question, right? So in the future, you're going to have a patient, take a skin or fat, make iPS cell, make cardiac cell, re-inject back to the same patient. So we're trying to do this in a large animal model to simulate, how difficult it is to do this. And this is the last point that I'm not sure how many of you are aware of. What is the cost effectiveness for patient-specific autologous therapy? Everybody wants autologous therapy for human iPS cell, right? I give my skin, make iPS, make cardiac, re-inject back into me. But remember, the MO of any biotech company is to have a high return on investment. So it makes sense to carefully validate a few cell lines to avoid lawsuits and to sell to as many patients as possible to make money, right? So the question is, does it make sense to validate one line for one patient, and especially for acute disease such as stroke and myocardial infarction? So this is something that you have to weigh into as well. And that's why I think it's probably more likely in the future that you will see allogeneic iPS cells being used, meaning that take somebody's skin, healthy guy, make iPS cell, make cardiac cell, validate it, store it as a bank, create a lot of these, do a lot of quality control. Somebody in Texas gets a heart attack, pick up the phone, you ship the cells over. Right? So that's something that's a much easier model to demonstrate. So I kind of given you some of the hurdles that we're looking into. So the year 2020, hopefully by then, patient-specific iPS cells for regenerative medicine, drug screening, and these are the kind of topics that we work on in our lab. And so that at that time, 10 years from now, it's possible that company X has a scientific rationale and a viable business plan to treat heart attacks with allogeneic iPS cells. Company X validated a few of their top lines, perhaps using fat cells that I told you earlier, that have been generated using integration non-viral technique, using many circles that we work on, scaled up under GMP condition and tested for product consistency and purity. Company X then injects these cells, immunosuppress the patient with this co-stimulatory blocker that I told you, and then afterwards, patient get quarterly PET-CT scans to make sure that there's no tumor formation. Possible scenario, maybe. So I want to summarize by, again, going over the 3 major cell types. So this is, you got to get this when you go home, all right? Do we have adult stem cells in our body? Yes, we do. There are several clinical trials going on. I show you this, right? Several clinical trials. The data is so-so. The main problem is what? Cell death, cell death, cell death. And the same would also apply for cardiac cells that derive from ES cells and iPS cells. But the other question is, have you ever thought about this question? Does it make sense to take old beat-up cells from a 70-year-old patient and put them back to the same patient? Does it make sense? And I think you guys saw this. The analogy is, I want this guy's stem cell. I don't want his stem cells anymore, right? And likewise, I want his stem cell. I don't want his stem cells. So does it make sense to take stem cells from him and put it back into him? So that's one question you have to think about for autologous adult stem cell, right? Because after all, most of the people who require the stem cell therapy are this population, not this population, right? And embryonic stem cells, do we have these in our body? No, you don't have these in your body. These cells can self-renew and also can have pluripotency, but they're hampered by ethical and political debates, and these cells have the potential to cause tumor, right? I show you that, and they also get rejected. iPS cells, you don't have these cells in your body, but we can make it for you, right? From your skin, from your fat, and these cells are very similar to ES cells, and you can turn your iPS cells into beating cardiac cells. I show you that. And we think that this approach may one day be used for autologous. It's going to be very expensive, maybe for Dick Cheney or other people, or allogeneic stem cell therapy, which is more cost-effective for commercial companies. And so I want to just acknowledge basically the postdocs, my collaborators at Stanford, and then my funding support. And these are the guys in my lab that work here. And then if you have any questions, I'll leave my email here. But again, adult embryonic iPS cell, the differences, okay? So any questions at all? Yes?
I'm curious, because of the medical, legal, political ramifications and issues in this country, where is the most success being seen, and where do you think breakthroughs would likely occur? Is that going to be related to some of the issues we face from a scientific standpoint here, and as outside the U.S., will they make more progress in this area?
Yeah, I think the question is a very good question. The question is because of the ethical and political debates here in the States, would it allow an opportunity for other countries to catch up? And I think the answer is definitely yes. I think there's a lot of hassles that we have to deal with for those of us who work with embryonic stem cells. In Europe, they also have some hassles that they have to deal with. For example, in France and Germany, they also have quite a bit of hassles. You'll see the countries that have minimal regulations are the countries that are going to catch up in terms of their patent rights, in terms of their advances and things like that. But I still think right now, we as a whole in the States, we're probably 5 years ahead of, 3 to 5 years ahead of the other countries in terms of the technology. And that's why you'll see a lot of people come to the States to learn these technologies and go back to their country to do it and things like that. Yes?
Your argument about the how to make money from all of this sounded more like it was a drug company, but if you think of this as surgery, after all, if I have a bypass, you're going to take body parts of me, my veins, and you're going to graft them onto my heart. Well, let's say you do that, and then you also take some of my healthy heart cells and you do your magic on them and you re-inject them to me. It's going to cost hundreds of thousands of dollars, just like the heart bypass did. But maybe that's a better way to cure me.
Yeah, so that's exactly right. I think the question is it possible to do iPS cells, autologous iPS cells, and have the have the company do it or have the hospital do it? I think in the beginning you'll see the first couple publications, the first couple proof of principle will come from the hospital, meaning that we can do this. I mean, today, in fact, if you want to be a volunteer, we can do this. And afterwards, we'll just thump our chest and say, hey, Stanford is the first group to do autologous iPS cell therapy. But sooner or later, somebody needs to take that technology and, quote unquote, commercialize it. Without the commercialization part, it gets much more difficult because it's limited to major universities that can do that. Let's say, for example, you're a patient in, I hope nobody's from Mississippi, but University from Mississippi, and they don't have somebody who do this type of research. It gets very, very difficult to do it.
That's the way it is with heart transplants and all these kinds
Yeah,
of
that's true.
operations.
Yeah.
This is just another kind of
Exactly.
operation.
Yeah, that's true.
Let me actually ask you a part of that. So, I mean, obviously one of your concerns about that is just the cost.
Yeah.
Today, it takes you months of work and a lot of money to ride these cells. But then again, it wasn't that long ago where it cost $6 billion to sequence one human genome. Nowadays, we can do it for $1,000. Is it conceivable that in your vision by 2020 that this technology will become easy enough and automated enough that actually may allow that technology?
Yeah, so that's a very good question. I think the cost will definitely come down. When we first started doing this, we were charging the NIH about $15,000 to make IPS line. Today, I can make an IPS line from you guys, any one of you volunteers, for about $3,000. So the cost is going to go down. I think the question is that, especially with the ES cells and iPS cells, there's this potential of bad things happening in the tumor and things like that, that you have to validate the lines very, very well. And the cost is not in the generation of the cells. The cost is actually the validation of these cells that's needed to satisfy the FDA. I mean, they want product safety, quality control, each lot consistency and things like that. So it just gets more difficult compared to autologous stem cell, which is basically I go in with a big needle, suck out your bone marrow, nothing happened to the cells, put it back into you. These cells are outside of your body for about 6 to 8 weeks, actually more than that, depending on what cell type that you want. For cardiac cells, probably outside of your body for about 12 weeks, 14 weeks. Yeah. Yes.
Can you talk a little bit about what happens when you inject these cardiac cells into a damaged heart with scar tissue? Does your heart get better?
Yeah, so I show you some data where the clinical trial is. I think so far, if you look at the clinical trials carefully, this is conventional therapy, and this is conventional therapy plus stem cell. It's minimal, 3 to 5 points in terms of ejection fraction so far. So a lot of us are figuring out why is it that it's only improving this. And I show you an example of injecting these cells into the heart.
With the newer stem cells.
Newer stem cells, or actually the earlier, the adult stem cells, I show you those animal models. What happens to the cells when they inject?
Yeah, they die.
They all die.
Right.
So wouldn't it be nice if somebody, some smart guy, figure out if you inject the cells, and these cells for some reason they don't die and they actually persist there and do something, right? So the cell death is going to be a major problem, right? It is a major problem.
It is
yeah.
a problem now.
It is a problem right now. Yeah.
See, the level of improvement in function in most of those studies, which are not controlled, has been duplicated by using just a cell-free liquid, which you can also inject into the heart, which stiffens the heart muscle wall in the area of the scar and can produce the same level of benefit. So the other piece that is really important, if you're going to do a study, we like to use controls. None of these studies that have been described so far use any controls.
So this derived cardiac cell, you expect that to go to the scar tissues and replace them?
So these, okay, so that's a very important point. I take your skin, I make iPS cells, I differentiate the cardiac cells. I know these are cardiac cells because they beat on a dish. They look like cardiac cells to me, to my eyes. I put it in. Right now, the major problem is a lot of these cells still die. If somehow in the next 5 to 10 years, I figure out a way so that when I inject these cells in, they don't die, then yes, you will get in the heart these cells, cardiac cells, that are generated from your skin that persist in your heart. The other approach, the very, very first study I show you with the mouse in which the whole heart lights up with green color, is taking the bone marrow cell. Taking your bone marrow cell, inject into the U, and earlier there's some groups showing that these bone marrow cells all become cardiac cell, which in retrospect is not possible. So bone marrow cells do not all become cardiac cell, but your skin to iPS cell to cardiac, I know I can do it, right? Yeah. Yes.
So even if we can overcome the death issue, which hopefully we can, it seems like it's not enough for the cells to live, but they also have to be mechanically and electrically coupled into the rest of the heart tissue that's still alive, where it doesn't really matter.
Yes,
They're
yes,
there.
yes.
Do we have evidence that they will do that? They will self-organize, or we can figure out how to make them self-organize such that they'll do the right thing?
Yeah, so right, it's a very, very important question that you've raised. I think the question is, even if these cells survive, I take your skin, make iPS, make cardiac, inject these cardiac cells into the heart, and after 3 to 4 years, I figure out the cells, how to make the cells survive. Maybe the cardiac cells I put in is just kind of like aloof and doesn't really interact. Or maybe the cardiac cells I put in is actually doing something. We don't know. We don't know at this point whether they're mechanically or electrically conjugated with the whole myocardium. That's another things that we need to figure out as well. Yeah. Very good question.
Like in vitro, that they will appropriately organize.
So I think a lot of people are approaching that from several angles. One idea would be, if you just inject these cells and you don't give them the cues, and maybe one of them is turning this way, and then the other one is turning this way, and then the other one is turning that way. So they just randomly organized. One idea some people are thinking about is basically use tissue engineering patches, right? Have a patch, seed the cells, and give some kind of shear flow so that all the cells line up this way, and then take that patch and put it onto the heart. Yeah, very good question. Yeah. Yes.
It's just a definition question, but you want to go home knowing what these are. In addition to our potent cells, you said we don't have in our adult bodies, but do we have pluripotent cells? I'm thinking of actos that are supposed to be cells that differentiated into either fat or bone, and actos are
yes.
more fat.
Yes.
Is that also a pluripotent cell?
Yes.
That's not an induced.
That's a very good question. So there's 4 terms. Totipotent, T-O-T-I, P-O-T-N-T. Pluripotent, P-L-U-I, P-O-T-N-T. Multipotent, M-U-I-L-T-I, and unipotent. So the totipotent is basically the cells that you get from the sperm meets an egg. They can become anything. The pluripotent is at that stage, at the 2-week to 3-week stage of the in which we take out the inner cell mass out of a fertilized embryo, and these cells can become pretty much every cell type of the body, but they can't generate a human. The multipotent is the one that you and I have. For example, if you take your fat cell, your adipose stromal cell, they can become bone, they can become cartilage, they can become mesenchymal cell, they can become fat. The unipotent is skin, right? It doesn't become anything else besides skin. Heart, it doesn't become anything else. It's already committed to become a skin cell. And this is the reason why it's easier to take a fat cell, because a fat cell is multipotent. I show you the data to push it back into pluripotent. It's much tougher to take a unipotent skin to push it back to pluripotent. Yeah. Yes.
So how long the cell survive from the mouse model? We transplant from the alveolar to the heart and the integrative moving cells.
Yeah, so in our experience, if you look at those, we went through the exercise in which you guys could tell me. Typically about 6 weeks, the cells will survive in the heart for about most of the cells will die off within the 6 weeks. The bone marrow cells into the heart. Yeah. Oh, that one. So yeah, so that was a paper. Basically, what they did was so this whole field started back in 2001, in which, again, as I say, a group in New York took bone marrow cells from a green-colored mouse and injected into a bone marrow into the heart of another mouse that has no green color. And by day 10, day 9 actually, day 10, they showed that all that all these green dots right there have become cardiac cell. And that's how it got everybody excited, right? So, again, as I told you, we cardiologists are not the smartest out there. We're almost like surgeons, right? So, whoa, this is amazing. Take bone marrow and put it into a cardiac cell. So a year later, we were already doing this, injecting bone marrow cells into patients. Yeah.
What did they get wrong?
What did they do wrong?
What did they get wrong? You said that basically that paper was incorrect.
Well, I'm not saying this is being recorded. I'm not saying it's incorrect. I think it's just like anything in science. It's all shades of gray, right? So there's some science into it, but I think at day 10 it doesn't all become cardiac cell. If there are some bone marrow cells that are becoming cardiac cell, it's very, 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 very minuscule amount. It's not like the whole heart becomes a cardiac cell.
From what he just said, it would be an interesting step if we could stimulate the heart to make its own cells again, right?
Yes. I think. Yeah. Yeah. I think the question is it possible to stimulate your own heart to regenerate? That's also very, very controversial in terms of the ability to do that, because I told you that most of your heart cell is unipotent. They're already committed to become heart cell. If they die, they die. There are some residual stem cells that are inside your heart, and these residual stem cells inside your heart, upon seeing some kind of damage, they can proliferate some and basically, produce some blood vessels or doing some kind of rescue, some kind of repair. But overall, the endogenous process of repair is not good enough, and that's why you see heart attacks, heart failures, and things like that. And yeah, there are some, including us, we're trying to figure out how do you turn on those cells as well. How do you turn on those cells in the heart? It's not like I can just say turn on and it gets turned on. You got to deliver something, either drugs, and this drug that you give somehow has to be magical so that it only turns on the heart cell. It doesn't turn on other parts of your body. Or you got to deliver something which I'm sure you guys have heard, gene therapy. Inject some kind of gene into the heart, and then the gene therapy turns on something in the heart. And let's get into another lecture in terms of the pitfalls of gene therapy and how it works and things like that. Yeah. Yes.
Any hope of ever eradicating the carotenoid-producing cells in the petri dish?
I'm sorry. Is it?
Any hope of ever eradicating the carotenoid-producing cells?
Yeah. So the question is, any hope of eradicating the teratoma-producing cells? Yeah, I think a lot of us are making good progress. I think, with time, remember, embryonic stem cell was only discovered in 1998. So this is only 13 years. Within 13 years, I'm showing you these beating heart cells. God knows, your kids, my kids could be taking these cells and going to another level. So yeah, I think it's just a matter of time, yeah. Yes? What happened to the stem cells when they die? We don't know, and that's the question we're trying to figure out. We're trying to figure out why they die. Oh, it gets cleared up. Basically, cellular debris gets cleared up by the macrophages in your body. Yeah. Yes.
From a design standpoint, is there a reason why you can find in your mind as to why of all the systems, the brain and the heart do not make stem cells enough to create their own repair system? You can tell why the skin we would need it to regenerate easily, but why out of all the systems that the brain and the heart don't come with that basic?
Yeah, that's a very tough question. I think the question is, why is it the heart and the brain doesn't have that much a stem cell compared to the skin, compared to the GI tract? It's a tough question. I guess, evolutionarily, I mean, if you think about it, for skin, we're always exposed to the external trauma and things like that. We make a wound cut and things like that. So you got to have a skin cell, basically a stem cell that kind of constantly turn over and to replenish. And same thing with the gut. We're eating a lot of food. There's trauma and things like that. You got to have a stem cell to replenish. For heart, in which it's an organ. And there are some stem cells there, but I guess it's less, it's replicating less. Why is it by evolution? It's doing less. I can't explain that, but I think one observation you can see is that what are the most common type of cancer? The most common type of cancer, for example, are blood cancers, right? Leukemia, lymphoma, and those are the cells that proliferate quite a bit. And because they proliferate to replenish our body, they also have a chance to get mutation and get a tumor. Whereas it's very, very uncommon to get a primary cardiac tumor, right? Because again, as I say, the heart itself doesn't regenerate much. You get brain tumor, but we know brain has some regenerative properties. But the number of patients who get glioblastoma is minuscule compared to the number of patients who get blood cancer or breast cancer, cells that proliferate quite a bit, or gut, GI cancer. Yeah.
But just one analogy, although our skin does repair itself, if you amputate a limb, the limb doesn't regenerate. Yet if you amputate a tail on an iguana and other lizards, it does regenerate. So there actually are species that have maintained or by biological selection have developed the ability to rebuild part of their organism when that part gets damaged. So the process is part of a native biological process. We just need to figure out how to make it work in the heart.
So any other questions? I think if there are no questions, thank you for being such a participating audience.
For more, please visit us at stanford.edu.